We're so happy to have you here today. This is obviously a really important topic, and um, I don't think I'm speaking only for myself here that this is a topic that most of us in primary care are not comfortable. Certainly on the internal med side, I know we have a lot of our family medicine colleagues on today too, and I would imagine, are more comfortable with it than we are. But even then, I'm guessing that most of us are kind of holding on to some of these kind of outdated ideas and what have you. And I think John and I were talking that from an educator standpoint, then we're passing that same kind of wrong
Mhm.
information to trainees and stuff. And so, John has really set up a series of talks over the year, this year, focusing on this to try to make sure all of us across our KU primary care groups are up to speed on this. And so thanks, John, for organizing this. I think it's going to be great. I sent out an email to everybody this morning, but I'll be pretty brief with Dr. Kling's introduction. But she's coming to us from the Mayo Clinic down in Arizona, where she is the chair of the Division of Women Health Internal Medicine, as well as the assistant director of the Women's Health Center. And I think Dr. Kling is just a really a preeminent expert in this area, and I think it's going to be a perfect kind of expert for us to kind of learn from as we kind of start this series. And so I put some other podcasts that she is involved in. So today's, I think we'll probably scratch the surface, I'm guessing. And so there's some additional podcasts there, and then we'll have more coming down the way over the next few months. So thank you, Dr. Kling. We're happy to have you here.
Thanks for inviting me, and it's amazing to be with my people. Oftentimes, I get asked to speak in OB/GYN conferences, which I guess we're all each other's people, but as internists, I think our brains are structured a little bit differently sometimes. And if people are like, wait, women's health internal medicine, what is that? Our practice is a hybrid model where we provide primary care mostly to cisgender women, but I have some cisgender men and transgender people in my practice. And then, because of our expertise in menopause and sexual health, we offer consults for menopause, including complex menopause, hormone therapy, sexual dysfunction, and we have a high risk breast clinic. So that's kind of the clinic, like in case you're wondering, like, what is my clinical practice or expertise look like? That's how I'll approach all the questions that you'll ask today. So thank you for having me.
Yeah, we're so excited. This stemmed from there's actually a Curbsiders episode with a different person talking, and they were just like it was just like mind blowing. And it was the first time actually that I had heard that there were these changes being made to the black box warnings that have really been around for the last 20 years or so. Because like whenever I was going through training, no one was talking about menopausal hormone therapy. I mean, this isn't something that we learned about because it was just like this big scary thing. And anytime we were presented with it, it was off to a specialist. And it's like something where I feel like we should be empowered at this like kind of like juncture as the FDA kind of weighs back on its restrictions and to feel empowered in doing this for our patients. And so and when I don't know anything about it, I can't teach my learners. And when I can't teach my learners, they can't teach theirs in 3 years. And so that just feels really bad. And so we're going to do a few different things. We're going to have some kind of like free text where you guys can text over the chat function, but I'll ask a couple of questions and we'll have discussions around those briefly. Dr. Kling will present some slides that largely kind of go over the Women's Health Initiative study and kind of what it looked at and kind of maybe some of the problems with the study and why it kind of led us down this path. Dr. Kling has these just incredible slides for this grand rounds that she's giving, and I feel so bad because I jostled with just being like, you know what, you just present that lecture because it's so good. But I ended up doing kind of what we normally do, but I mean, it's interactive. It has pictures all over the place, and I only have one GIF here, so I feel very bad. So without further ado, so really the objectives for today are discussing the historical context of the rise, fall, and rise again of menopausal hormonal therapy, discuss inappropriate hormone use and the associated safety concerns, and discussing the process of selecting appropriate menopausal hormone therapy candidates. You might notice that I say menopausal hormone therapy instead of HRT, and when I first made this lecture, I sent it to Dr. Kling and she's like, hey, just FYI, it's not that anymore. It's MHT, and there's kind of been a frame shift in how we address it. And so if you would just kind of give some context to that and why you think that the difference is important to recognize.
Yeah, absolutely. So, and a lot of this is motivated by the Menopause Society, which is really the premier kind of research and clinical organization that puts out guidelines, including the most recent position statement in 2022, which all the guidelines from the Menopause Society are open access. So you can even pull it up on your internet browser and either reference that while we're talking or have that for future use. But the decision to go from HRT to MHT was the idea that menopausal hormone therapy is meant to treat symptoms as opposed to replace estrogen. And so it's a better descriptor of what hormone therapy is doing by calling it menopausal hormone therapy, and gets away from this idea that we need to measure labs and women are deficient and we need to replace something. Instead, it shifts it to we're using this treatment at the time of menopause to manage symptoms. The only exception to the terminology is for women that go through premature menopause, so less than age 40, or even early menopause, which is less than age 45. There's robust data that shows those women suffer long-term health consequences if they're not on hormone replacement therapy. And in that situation, we're replacing it to create more of a physiologic milieu of a premenopausal woman, to help with her bones, her heart, her brain, et cetera. And we can talk as we get to the risks and benefits how there is data to support that. Some of that has unfortunately been extrapolated now in the media, saying menopausal hormone therapy helps prevent heart disease and dementia, which we don't actually have that randomized control data. But so just to get us back on track here, generally menopausal hormone therapy for women who go through menopause at the average age, and then hormone replacement therapy for premature menopause.
Um, this is something where I just want to get people's kind of input because I think we've seen hormones be used, whether outside clinics or wherever we're seeing it used, and just hormones in general to try and help people feel better, but maybe in an inappropriate way. I just would like people just to put some things in the chat and we'll just kind of talk about them, about different ways that I've seen hormones being advertised and used to help women in ways that may not be evidence-based. And so whenever I think about this, I think about my women who are going to like medical spas and they're getting this slew of labs drawn and they're started on adrenal essence or armor thyroid and everything looks kind of normal, but they're using different cutoffs. And so I have I have a lot of people that I have to counsel on for that. Um, Hormones used for sex drive, and then testosterone for libido and energy, skin, testosterone for females for libido. And then we talk a little bit about this, Dr. Kugel, about the troches and the pellets using DHEA. And then like I'm doing it for my bones is what they'll say, even though they are younger, especially my labs were off, things like that. So we see tons of different kind of ways that this presents to us. I don't know, Dr. Kling, do you have I guess it goes down to the next question is with so much medical hesitancy that we kind of encounter nowadays, why do you feel like this is a territory in which a lot of women, especially I feel like younger women now are approaching us and saying like something is off with my hormones and like how do we counsel people on like natural aging, normal hormone kind of imbalance and like what they're trying to get treated for?
Oh, that's a really great question. I don't know if I have all of those answers, but it might be wrapped into the history, which we'll get into a little bit more. But because of how really the findings from the Women's Health Initiative were shared broadly, and maybe some would say even inappropriately to women, and then how our response in medicine was just to not do any of it. I think it left this gap where women felt not heard or seen as it relates to their medical conditions. And that was just perpetrated for so long. And we're just starting to recognize that. And so, in a place where you're not feeling like your symptoms are being heard, you're going to look for solutions. And I think we're taught to say, oh, yeah, but it's not your thyroid. Oh, it's not your thing. Instead of shift it and say, hey, I hear that you're having these symptoms. Let's figure out how to support you through this very natural period of life, whether that's during your menstrual cycles or during perimenopause or menopause. And there might be a role for hormones, there might not, but at the end of the day, I'm here to work with you along that whole process.
Yeah, I feel like there's so many times when it's like there's just like this holy grail, that they're seeking. And I do feel like hedging expectations is where I have to kind of jump to. But like also you just can't discount people just because they're young and they feel like something's off. Um, so we're gonna shift into kind of the Women's Health Initiative problem and how we ended up where we are today with so much hesitancy. And this is where Dr. Kling's gonna share some of her slides and I will advance them for you, okay?
Perfect. And I put a link in the chat about from the National Library of Medicine, the clinical utility of compounded bioidentical hormone therapy for people to reference, and we can talk about that later. But that addresses the whole Troche pellet debate. But it's helpful to think about that in the context of this history, because really the history goes back to July 9th, 2002. You saw that eruption. There wasn't an actual volcano eruption. It was an eruption in the media when the Women's Health Initiative was closed early, specifically the estrogen plus progestogen arm, because of a higher risk of heart disease, stroke, pulmonary embolism, as well as breast cancer. And this was a shock to so many. And what we saw were headlines like, hormones will kill you, hormones cause so much breast cancer. They took a lot of the relative risks and presented them as absolute risks. So things like there's a 25% chance of getting breast cancer, not recognizing how to take that information and translate in a kind of appropriate way. And that's when prescriptions for hormone therapy declined significantly. And in fact, before you go to the next slide, before the Women's Health Initiative, Premarin, oral conjugated equine estrogen, was the most prescribed medication in the US. Not the most prescribed medication to women in the US, and not the most prescribed medication for menopause. It was the most prescribed medication in the US. And you can see, I have a graphic I can share with you later that shows just how it drops so significantly after the WHI. And as a refresher, the WHI was the largest randomized control study in the 1990s that looked at what the most common formulations of hormone therapy were being used at the time. And the primary outcome was coronary heart disease. It wasn't breast cancer. It wasn't treatment of hot flashes and night sweats. Really, it was trying to demonstrate or assess if hormone therapy reduced the risk of heart disease in women. And so if you advance the slide, you'll see that there was over 161,000 women at 40 different clinical centers that were either randomized to oral conjugated equine estrogen at 0.625. I call out these formulations and the specific numbers because that matters, and some current formulations we have as well as the current formulations we use. But they use CEE plus MPA for women that had a uterus, or CEE alone for women that had a hysterectomy versus placebo. And when the findings came out, yeah, go ahead and go to the next slide. It really caused a lot of folks to scratch their head, people in research and clinical practice, because we thought menopausal hormone therapy was good for the heart. We all know that menopause represents a period of increasing risk for cardiovascular disease. In fact, we can see that in the epidemiologic data where women have lower risk before menopause, but then unfortunately we beat men, post-menopause as it relates to rates and risk there. And before the Women's Health Initiative, there was a ton of observational data and animal data that showed that hormone therapy nearly cut coronary heart disease risk in half for women. And so at that time, before the Women's Health Initiative, if a woman walked into her physician's office, they may have prescribed her CEE, even if she wasn't having symptoms, because we thought it was protective against heart disease. But us in medicine want randomized control data to demonstrate that. And that's why the Women's Health Initiative was put together. And then why it was such an eruption when it was closed early. And like so many other things in medicine, this made us step back and say, why do we see this difference between the randomized control data and the observational data? And that's where we get to the timing hypothesis. So when they looked at the design of the Women's Health Initiative, they realized that the average age of women enrolled in the Women's Health Initiative was 63 years of age, whereas the average age of menopause in the US is 51 years of age. and wondered, does the risks of side effects matter based on the timing of initiation? And so what you see here is the sub-analysis that the WHI did by decade of year of when women started hormone therapy. So 50 to 59, 60 to 69, and 70 to 79. I know there's a lot of text on this slide. You don't really have to look at the text. I just want you to look at the blue bars. I think we could all agree that the more right you go, so the older the age you're starting on hormone therapy, there's a lot more blue bars. And that means there's a lot more harms and worse outcomes, including coronary heart disease, breast cancer, stroke, PE, et cetera. But if you just look at the group of women that started hormone therapy 50 to 59, they actually had lower risk in all of those categories. And the WHI has followed these women 18 years past randomization, so 13 years past hormone therapy use, and found those trends persisted. And if you go to the next slide, you can see for the women that are 50 to 59, that's all that's presented here. The top figure is for women that were just on estrogen. The bottom is estrogen plus MPA. And they actually found more benefits than risks. The dark blue bars are where women did better in these categories. The light blue bars are the risks. So you can see that women were found to have lower risk of diabetes, fractures, all cancer types, all-cause mortality, and very intriguing is lower risk of breast cancer if they were on estrogen alone versus placebo. That data has been followed up to 20 years after the Women's Health Initiative and found that they continued to find that lower risk, as well as lower mortality if women had used CEE during menopause. So these have been published, 2018, 2020, but none of them have made the same splash in the media like the initial closure did. Furthermore, we've had smaller randomized control trials like the KEEPS and the LEAP study that have really supported the idea that if you start hormone therapy early in menopause, that the benefits outweigh the risks and it's safe as it relates to heart, stroke, et cetera. And that's what's informed the Menopause Society guidelines and other society guidelines, Endocrine Society, European Menopause Society. And if you go to the next slide, you'll see how we've translated this data into the most recent recommendations. So from that position statement in 2022 from the Menopause Society, they say the indications for the use of menopausal hormone therapy are first for treatment of vasomotor symptoms. I didn't mention that in WHI because they didn't look at symptoms, and that's not what it is for, but there's plenty of studies. In fact, the ACP is working on a review that will come out looking at the most effective tools for hot flashes, but it is hormone therapy. It's the first line treatment for hot flashes and night sweats. It can also be used for the prevention of bone loss. However, we don't have RCT data that shows that it's for treatment of osteoporosis. And then I mentioned this earlier, that it's indicated for the treatment of premature menopause, as well as the genitourinary symptoms. Now, if a woman's just having genitourinary symptoms, you can use targeted treatment, low-dose vaginal estrogen or vaginal DHEA, but systemic hormone therapy, when used for the other symptoms too, will help with that. So I can't remember if that was the last slide, John, or if I have okay. Yeah, this is why I included this slide is because there's so much now since the FDA black box warning came out. Even Dr. McKay suggested that there might be some role for hormone therapy for prevention of heart disease and cognition. And as I had mentioned earlier, that we don't have that data. Certainly the observational, or rather the sub-analysis of the Women's Health Initiative is hypothesis generating and very provocative, but the current state would say hormone therapy is safe and doesn't increase those risks for average risk women, but we shouldn't be recommending it for dementia or cardiovascular disease prevention for women going through menopause at the average age. And yep, that's exactly, I think, what these 2 points here are saying. And then always, if we're not going to recommend hormone therapy for that, what do we recommend? All the stuff that you all know, lifestyle, healthy habits, etc.
Okay. Yeah, there's a lot to digest there, especially with like the absolute risk reduction and like events per 10,000 people and very marginal, if any, difference in a lot of them, which is great. And it helps so much with the symptoms, and it's just,
Hmm.
and we can talk a little bit more about that when we get a little bit deeper into it. But so the cases that I kind of present are when a patient is younger, and then when a patient is 20 years older, and essentially it's just a 32-year-old comes to your clinic and she asks about going to a medical spa. She notes that she's curious about hormones, having a panel check, see what her levels are. She has a friend who went to a clinic and she's just feeling great after she went there. And this is something that I think is not exactly what we're trying to get at with this lecture, but I think it's something that we see so frequently. I would love to get your just professional perspective on this. So how do you counsel patients prior to these visits? Do you encourage them? Do you say, go check it out, see how you like it?
Uh, no, not
Okay.
typically. I mean, I think, and how do I say this diplomatically? Some of these practices, they're incentivized by selling things to women, and I feel like that's such a disservice to women. But what they do well is they listen to women, and I think a lot of women feel gaslighted as it relates to um, medical care, and so. I believe truly that all of us in our positions, our frontline positions, can offer this service to women and give them this evidence-based approach. Uh, it's, checking hormone levels when somebody is menstruating is not very helpful unless you're concerned for something like PCOS or maybe POI. But outside of those, certainly if she's having symptoms, making sure she gets a comprehensive evaluation to make sure she's not anemic or has hypothyroidism or some other condition, which is not being, that's not what's being offered in these clinics. So instead of making it a us first them, which I guess I just did right there, but making it about evaluating the underlying cause why a woman is seeking that care, and then trying to figure out what her main concern is, and letting her know that we have tools that she can use in our practice to help her feel better.
I've run into, and I didn't mean to put you on the spot. That is my bad.
No, no, that's
Sorry.
okay.
So I've run into times when, especially, I mean, with a lot of my men, but also with my women that come in to see me, they're like, well, I saw one of the clinics already, and they told me that, oh, well, it's technically a normal level, but people feel better with higher levels, or actually, there's more research, and they'll have these research articles that they'll hand me that are not good research articles, and I struggle to find a way to talk to them about that.
Yeah, I guess I've learned that it's hard to convince somebody if they strongly have a strongly held belief about that thing helping them, and instead try and shift the conversation to tell me more about the symptom that led you to seek that treatment. Um, that might be different than when you're talking to somebody that's like practicing in those clinics, but for the patient themselves, trying to take them out of the middle as much as possible. And then if they decide that that's what they want to continue doing, making sure they're doing it as safely as possible. But a lot of these clinics, and I'm using it broadly, I should maybe be more specific. In Scottsdale, we have a lot of clinics that offer the custom compounded hormone therapy, pellets, et cetera. That grew to meet a need post WHI when women were not getting care for their menopause treatment. And unfortunately, a lot of the claims that were made about those treatments just have not been substantiated by data. And that link that I put in there was the National Academy of Science doing a deep dive into that question. Are custom compounded bioidentical hormones safer than the bioidentical hormone therapy that we can prescribe that are FDA approved? And really, they did not find that there was data to support that. And so sometimes I'll lead with that with patients, like, um, you know, these claims have not been supported by evidence, and I want to make sure you're like you deserve to have evidence-based care to address your medical symptoms. So let's talk about something that we know is going to help and is going to be safe.
Okay. Yeah, it's so helpful. And I'll let your kind of your the article that you sent kind of speak for itself on the second point, because I do feel like all of us really want to get into the actual menopausal hormonal therapy. So she's 52 now. She never elected to start hormones previously, and you continue to see her. She comes back to your clinic for an urgent care appointment because she's thinking that she kind of officially started menopause, but she's skeptical now about starting hormones based on everything that she's heard about it and based on your prior conversation saying you probably wouldn't recommend it unless it's absolutely needed. And things are told, her friends have told her that doctors have told them over the last 20 years. And so there's
Mhm.
a lot of hesitancy. And so I guess starting from the basics, how do you define menopause and kind of clinically distinguish this from menopausal transition? And why is that important when we're thinking about menopausal hormone therapy?
Yeah, perfect. I do want to try and make a point about the 32-year-old or 35-year-old. I'm sorry, I can't remember how old she was. The thing we do need to remember is contraception in that situation, because menopausal hormone therapy is not effective at preventing pregnancy and would be contraindicated for if she was pregnant. So if you are talking to that younger woman, just making sure she has a plan there, or considering birth control to manage her symptoms, which we can talk about when we cover perimenopause. But generally, menopause is defined clinically and retrospectively as after 12 months past the last menstrual cycle. We don't recommend getting hormones to confirm menopause, such as an FSH or an estradiol. Although many of you might be sitting there thinking, like, well, what about a woman with a hysterectomy or with an IUD, like a progestogen containing IUD that doesn't have a menstrual cycle? In those situations, if you really needed some clarity, you could check. I usually would do like an estradiol and an FSH. But if she's having symptoms suggestive of menopause and she's around that age, so perimenopause typically starts about 3 to 5 years before menopause, so putting women in the kind of mid 40 range. If she's having symptoms, then you can certainly talk about options for treatment, including hormone therapy, birth control pills, etc. Um, I know there was more to the question. I feel like, ask me, John, where do you want me to go from there?
Um, I suppose,
Can I jump in here, John?
Yeah,
I would kind of, there's some great things in the chat. Maybe we could jump over there here as
yeah.
well.
yeah.
But I guess as I'm kind of relearning some of this stuff, or maybe learning a lot of it for the first time, it sounds like if we have someone coming in, when we're thinking about hormone therapy, it sounds like, is it mostly symptom driven, or almost there's almost like this preventative component? Are we kind of going back to the 1990s where we almost give it, or is it purely we need to assess the symptoms,
It's symptom
vasomotor,
driven.
then we need to kind of start thinking about hormone therapy? Is that
Yeah. Yeah. It certainly, well, the pendulum does appear to be swinging very far to the side that it's more like that feminine forever pre-WHI era. I would say the data supports us using a symptom-driven approach. And what I have heard from women and other clinicians too, though, is, oh, even if you're having vasomotor symptoms, you have to wait until you're in menopause to start hormone therapy, which is not the case. Like, because perimenopause can be accompanied by a lot of really crummy symptoms, you could consider using hormone therapy at any point during the menopause transition. If we get a chance, or maybe I can send it out, the study of women across the nation, or the SWAN trial, characterized the symptom trajectories for women. They also identified that on average, women tend to have vasomotor symptoms, hot flashes, and night sweats for 7 to 10 years. And women that experience vasomotor symptoms during their perimenopause tend to have more and have them longer. Black women and Latina women tend to have more and longer duration of vasomotor symptoms too. But they found that about a third of women have severe symptoms that start in perimenopause and go years after their last menstrual cycle. I mean, their graphic shows it's still very high at 14 years post the last menstrual cycle. There's some lucky women that don't have very many, just have a few during the last menstrual cycle, and then a majority are somewhere in between that. So if hormone therapy is the most effective tool we have to treat hot flashes and night sweats, and if we know that hormone therapy benefit outweighs the risk for women less than age 60 or within 10 years from their last menstrual cycle, then that would suggest that women coming into your clinic that are around the perimenopause or menopause transition could be offered menopausal hormone therapy as a first-line treatment for those symptoms. The only prevention I'd say is for osteoporosis. If somebody's high risk and they're not having significant symptoms, but they have a strong family history or other personal risk factors that would put them at a high risk, and they had the personal preference for considering hormone therapy, that would be an area that you would have evidence to support using hormones in that situation.
We have a couple of really nice questions in chat that ask about what are the symptoms that women are coming to you and you're saying like actually being on a hormonal therapy of some kind will actually be beneficial to you to mitigate some of these symptoms. I know you showed that list of some of them, but then there's also a lot of women will come and say they're having insomnia, they're having more central adiposity. How do you counsel in that regard?
Yeah, great questions. And the more we study this, the more we're realizing there's so many symptoms that accompany perimenopause. And it's influenced by culture and all these different things. So in certain countries, women list frozen shoulder or shoulder stiffness as their main symptoms, and vasomotor symptoms are much lower. But what the data shows is that it treats hot flashes and night sweats. There's a lot of really good research looking into how it impacts sleep. And some studies that suggest that it helps with sleep if your sleep disturbance is driven by night sweats. If you aren't having night sweats, then estrogen alone or estrogen hormone therapy alone may not treat those sleep issues. And it falls to us to really evaluate, make sure there's not something else going on. The risk of sleep apnea goes up to about 11% after menopause from 3% premenopausal. Well, hormone therapy itself is, well, let me just say this first. Micronized progesterone has the side effect of sleepiness. And so I do see a lot of practitioners prescribing it exclusively for sleep. It's not indicated for sleep. And from the Women's Health Initiative, as well as some other studies, it was the estrogen plus progestin groups that did have that slightly higher risk of breast cancer. So if a woman doesn't need progestogen, I tend to not prescribe it. But I do have patients coming in that have been prescribed it for sleep. And so I just want everybody to know that's not an indication. It's indicated for endometrial protection when in combination with an estrogen. As it relates to weight, hormone therapy is weight neutral, doesn't contribute to weight gain or weight loss, but it does help with weight distribution. The reality is our bodies change around menopause, impacted by lots of different physiologic changes, and we tend to gain more weight abdominally. Hormone therapy helps attenuate that weight gain. I would say if a woman was sitting in front of me, had no other symptoms, and was just like, I want something to prevent my abdominal weight gain, I don't know if I would be inclined to prescribe hormone therapy in that situation. But the reality is most have a constellation of symptoms or bone risk that it might be a secondary benefit.
We just had someone talk to us about hypogonadism in men, and it was a lot of the same kind of idea. Like it can help with these things. We don't use it for these things, but it can help. But if we don't see the effects, we're not shocked, kind of thing. And so, another really great question was, and it kind of gets at this first point is when you're talking about this perimenopausal transition versus menopause, like our doses, and you're talking about kind of differences in treatment in OCPs versus MHT. I mean, is it the dose of treatment? I mean, how is that influencing how we treat them?
Yeah, that is a tricky situation. In fact, I'm going to work on a review I'll have to send out to all of you with a mentee of mine about management and perimenopause, because more women are coming in and asking for treatment at the time of perimenopause, even early mid 40s, and asking for hormone therapy, which we don't really have a lot of data on women in perimenopause and hormone therapy. We think probably it's fine. The biggest caveat is that it doesn't provide contraception. And so, menopausal hormone therapy kind of taken together is about 4 times lower than some of the lowest dosed birth control pills. Ethylene estradiol, for example, like a 10 microgram of ethylene estradiol or even 15 microgram, that's about the same as the 100 microgram or the 0.1 estrogen patch. And so it's a much lower dose. So it also doesn't help mitigate the bleeding issues that occur around perimenopause. And so oftentimes when I'm talking with perimenopausal women is I'll counsel them on that contraception need and offer them a couple of strategies. A continuous monophasic birth control is a fabulous option. It's enough hormones to treat the perimenopause symptoms, to provide contraception, and to address the bleeding pattern disorders that happen around perimenopause. Some don't want to use those and understand well the sexual side effects and other side effects with birth control. So another option, which is off-label, would be like a progestogen-containing IUD for the endometrial protection with an estrogen patch, gel, spray, or vaginal ring, or even an oral pill. Many of us are preferentially using non-hormonal or non-hormonal, non-oral estrogens like the patches and gels because it bypasses the first pass hepatic effect, and so it has a better safety profile. And I see lots of wonderful questions about like, what about women that are now in their 60s on hormone therapy? There's not an arbitrary age cutoff for stopping hormone therapy. If you ever learned, oh, only 5 years or 60 or 65, that was loosely based on the Women's Health Initiative or just the Beers criteria that decided to add hormone therapy onto the Beers criteria without like a evidence rationale for adding that. For women that are doing well on a safe formulation, they could continue it longer. They just need to be evaluated on an annual basis to make sure they haven't developed an absolute contraindication. And that is one of the reasons we'll start like a patch, because a patch would be a safer formulation to continue longer than, say, an oral pill of estrogen. If a woman's really motivated in that perimenopause stage to do hormone therapy, she could consider any dose. I usually start like a medium dose, and then a cyclic progestogen or progesterone would make sense, like a 200 milligrams of micronized progesterone for the first 12 days of the month would help make the bleeding as predictable as it could be.
Yeah, I guess, and then from this transition from the menopausal transition into just menopause, then you have to be, I'm sure it's much more difficult than if you're using for, some hormones for bleeding prevention, if that's one of their biggest symptoms, and then it's more difficult to determine when they hit menopause, and then we might go down on the doses in that situation. How do you kind of deal with that transition period?
Yeah. I guess in my view, I guess it doesn't really matter if they're on a menopausal hormone therapy formulation and they're doing well. I mean, as a woman advances in her 50s, so she's 55, 56, I usually would encourage her to reduce the dose of the estrogen to a level where it's still controlling her symptoms. But I don't think we like right when she's 12 months past her last menstrual cycle, do we have to reduce her dose? So we don't really need to know that point. The same, like if you choose for a perimenopausal woman to use a continuous monophasic birth control, we don't have to prove she's gone through menopause. And there are guidelines that say you could safely use that up until age 55. By 56, 95% of women will have gone through menopause. That sometimes is the trickier transition, is switching from the low dose birth control to a menopausal hormone therapy formulation. But there's options, and it certainly can be done.
Okay. Yeah, Brandon, go ahead. We have
Yeah,
tons of
so
questions
I
in the
don't know.
chat. We knew this was going to happen.
I can't remember if you have this in other slides, but and I apologize to everyone if this is like too basic of a question, but yeah, say we have this patient here. She's 52 and she's having vasomotor symptoms primarily. What do I start?
Yeah.
And then like there's patches and there's vaginal estrogen and there's oral like pills, what for somebody who's really at the basic level, how do you work through those different options and things that we should be thinking about?
Brandon, thank you for that question. I did my internal medicine residency at Mayo in Arizona, knowing that I wanted to be in a women's health internal medicine practice, did my chief year presentation on menopause. When I was sitting in front of my first menopause consult, I had that same exact question. So I don't think it's too basic of a question, right? Like if we haven't been taught it and we haven't been using it in our clinical practice, we need to know the basics. So my go-to is an estrogen patch, the twice a week estrogen patch. It comes in 5 different strengths: 100, 75, 50, 37.5, and 25. And depending, like if a 52-year-old woman, the 37.5 or the 50, which is the same as 0.0375 or 0.05 milligrams, those are reasonable places to start. And then if she's been amenorrheic for a year, then the 100 milligrams of micronized progesterone is typically what I recommend. And then I would encourage her to keep me posted on her symptoms. We don't adjust based on levels because the levels don't correlate with symptoms. We individualize based on her symptoms. So if we start that dose and she notices breast tenderness or vaginal discharge or headaches, it may be too high and you can just back off on the dose of the estrogen. But if you start it and after a month or two, she's not noticing much improvement, then you can go up on the dose of the estrogen patch. It's really common to have spotting when you start hormone therapy. So that's important both for us to know, but also for patients to know, because if they've not had a period for a while, it's like, what's going on? That's normal. In fact, we give them up to 6 months until we start getting concerned about it. Now, if she's having a lot of bleeding, you can increase the progesterone dose or decrease the estrogen patch. But I'm going to stop talking there because I can start getting into all the granular details, but I want to make sure you get the like basic go-to.
Really helpful. And I think just to make sure that we're kind of, combating some of the things that may be buried in our heads of the harm, right? So if let's say I err too high and I give her 75 or 100, and there may be some uncomfortable side effects with breast tenderness and things like that, but am I going to hurt her? And I mean, like, you know what I mean? Like, we're talking about all these things are still buried in our head around increasing risk and heart disease and stuff. But like, we're not going to do that. We're going to maybe give them other side effects, and we just kind of back off, and we can feel like we can play around within those dosing intervals.
I mean, if she's 52 and she's healthy otherwise, are you going to hurt her? Like, are you causing breast cancer by doing that? No. But it does rely on that evaluation, like we do so well as internal medicine and family medicine clinicians, right? And making sure we've assessed her cardiovascular disease risk. If she has a known history of coronary artery disease, then yeah, we might. Or if she has a history of VTE and a high or thrombophilia, then perhaps there is some data that shows that transdermal estrogen doesn't appear to increase VTE risk, but it's not a zero risk. So I think making sure we do our due diligence to evaluate the underlying risks, both cardiovascular, breast cancer risk, which is a whole other talk, but we can talk more about the breast cancer risk and how to evaluate that too. But really, more likely than not, you are going to help her tremendously, and she's going to come back and be your like most faithful patient and be so grateful for you helping treat her symptoms.
Okay, that's great. And
Yeah.
then you would get maybe like vaginal estrogen doesn't do much for vasomotor symptoms.
Right. Yeah,
So
it
more
doesn't.
sexual side or sexual, like pain with urinary frequency, your UTIs, that would be the estrogen might be a little bit better option. Is that
exactly? Yep. And if you were like me and you learned the diagnosis is vulvovaginal atrophy, the update has been to make the term more broad and also not label women with shrinking vaginas, which is what that term means, right? That it's now the genitourinary syndrome of menopause. So it acknowledges that it's not just the vulva and the vagina that are impacted, but it's the periurethra and the urinary system, and vaginal estrogen, which John, I think you're commenting on Rachel Rubin's interview on Curbsider. Dr. Rubin does a beautiful job of advocating for low-dose vaginal estrogen. She's a urologist and will tell you very compellingly how this not only treats these important quality of life symptoms, but also prevents urinary tract infections. And if any of you do any hospital-based medicine, you're taking care of older women with sepsis related to UTI. And so this is a very easy, low-cost, safe treatment that'll help prevent urinary tract infections. And so if she comes in and she's just having urinary urgency or dryness and pain with intercourse, a low-dose vaginal estrogen, there's a cream, there's a tablet, there's a capsule, and there's a ring, all that are applied into the vagina. Apart from the ring, it's twice a week as the maintenance dose. Or the intravaginal DHEA, which is prasterone, or Intrarosa, which is a nightly tablet. or ospemifene. I mean, you can use ospemifene, but those would be your go-to treatments for the vulvovaginal and genitourinary symptoms. One question that does come up is if she comes in and she's having both, like she's having a ton of vasomotor symptoms and she's got vaginal dryness, does the systemic estrogen treat the genitourinary symptoms enough? And for some women, it does, but for many, it doesn't. And it is safe to add a low dose vaginal estrogen in addition to a patch of estrogen and a progesterone.
Okay.
Yeah.
Yeah, that's helpful. So primarily the reason for having this, because I think we're going to have Dr. Vestal come on and I think really sort through the logistics of like, when do we switch? What other formulations exist? But this is a way to tell us like, be comfortable doing this, like start doing it, try it. This is the change. And so we have a lot of questions in the chat, and we're going to get to some of them because I think we could go on to the next thing. And really, I just want to make sure that we are cognizant about past medical history. We really need to be aware of absolute contraindications, and then kind of what getting, and then we kind of talked about a little bit about getting off or doing it past those recommended lengths.
Yeah, the absolute contraindication list includes a personal history of coronary artery disease, stroke, blood clot, severe liver disease, and breast cancer or hormone responsive gynecologic cancer. There's it lists in the guidelines a relative contraindication, or just maybe contraindication is not the right term here, but to be use caution with women with a history of endometriosis, because it may flare their endometriosis. The European Medical Association just came out with guidelines for women with endometriosis and hormone therapy and said, even if you have a hysterectomy, consider using progestogen to help prevent the recurrence. But that I think I kind of think of that as a separate thing that really I'm assessing to make sure, has she had a heart attack? Has she had a stroke? Has she had a blood clot? Does she have a history of breast cancer or severe liver disease? I might ask about her gallbladder history, like gallstones. There's a risk, especially with oral estrogen, of contributing or causing issues with that. But outside of that, there are no other absolute contraindications.
Okay. So Dr. Sabgati asked if someone has like fibrocystic breast disease or dense breast tissue, does it dissuade you in any way from using MHT?
Well, that would impact a huge amount of our population, right? 50% of women have dense breast tissue. So it certainly enters into the conversation. We know increased density is associated with higher risk, and I may follow up with that woman to figure out what her personalized risk is. Even if she has a greater than 20% risk, that's not an absolute contraindication to hormone therapy. In fact, there's really no data that has looked at that specific population. And it's so nuanced that it really depends. This is maybe a little provocative and not appropriate to bring up while we're really going over the basics, but there's data to suggest that oral conjugated equine estrogen at 0.45 milligrams, so lower than what was studied in the Women's Health Initiative, but in combination with bazodoxifene, which is a SERM, the brand name is called Duave, that medication, which is available to treat hormone therapy or treat menopause symptoms, may actually help prevent breast cancer. And there was a study presented at ASCO that looked at that. It was 115 women, but showed that it had positive impacts on the breast, specifically in women with DCIS. So, I mean, it just goes to show that it all depends. And a woman like that, I don't think the answer is no. It may mean just additional counseling and evaluation. And it might be that she uses hormones for 5 years and she does enhanced surveillance as opposed to longer term.
Okay. What about vaginal estrogen in patients who have absolute contraindications but severe GU symptoms associated with menopause? Are topicals totally fine
totally
across the
fine.
board?
Yeah.
Okay.
Yeah, I mean, I just came back from the International Society for the Study of Women's Sexual Health, where we had a very heated discussion about hormones post breast cancer, including vaginal estrogen. And this is also very nuanced. You know, not all breast cancer or cancers are the same, but for the most part, it's safe to use vaginal estrogen in women that have breast cancer or have a history of breast cancer. Outside of that, it's safe all the time. If she's had a VTE, a heart attack, a stroke, vaginal estrogen doesn't get absorbed more than we would anticipate postmenopausal levels. And we haven't seen in large, robust studies that it increases the risk of any of those things that we're always trying to prevent for our older patients.
Okay. Um, could you just give us, if you could give us a 2 minute kind of talk on how you stop MHT at the end of the day or what that looks like for you? Because we are running out of time and we knew this was going to
Yeah.
happen. This is my fault. But if you could help us out, that'd be great.
Yeah. And before we're all wrapping up, I'm putting a narrative review. I recently had the privilege of writing in the Green Journal for OB-GYN about testosterone and HSDD. So if you want a little teaser for the ACP conference, I'll be talking about that. Yeah, so it was in the 2022 hormone therapy position statement that they updated the language to say that there shouldn't be an arbitrary age cutoff for stopping hormone therapy. And most of us would say, hey, as a woman gets closer to 60, we can consider titrating down or off of hormone therapy if, we know 51 is the average age. Women have symptoms for 7 to 10 years. As she gets closer to 60 and beyond, her risk just because of age of things like heart attack and stroke are going to go up. So if she doesn't have to be on it and she's not having symptoms, then we can wean down and off. The reality is a lot of women have a recurrence of symptoms after stopping hormone therapy. And so you could certainly try to wean her down and off. At a minimum, get her to the safest formulation. So an estrogen patch at the lowest dose with the micronized progesterone. And if there's a motivation to stop either her or you, consider a non-hormonal option to bridge her, especially immediately following coming off of that. There's no clear data to say what's a better technique if cold turkey versus a taper is better. Most of us have found anecdotally, I know that's not the best way to do things in science, but I don't think there'll ever be a randomized controlled data largely in this, but we found tapering tends to be tolerated better. So slow, like giving her the control of reducing the estrogen dose. I keep the progesterone dose the same, 100 milligrams at a minimum until she's completely off of her systemic estrogen. You don't need a progestogen if you're on just the low dose vaginal estrogen. And so if you will likely continue that, even if you have her off of the patch or the gel or the spray.
Do you ever use like non-hormonal treatments in someone who's like, they were severely symptomatic? Do you ever use anything to like cross titrate over to something that's non-hormonal, or is that just like
Sure.
it in? Okay.
Yeah. And now we have three FDA approved non-hormonal options: paroxetine, brand name Brisdel, the low dose 7.5, fezolinetant, brand name is Bioza, and then elinzanetant that just got approved last October, Linquit, that are really making a significant impact for women. And so using those, if you can get them covered, can be very helpful.
Okay. There are just a million questions in chat. This is such a good sign, right? So I cannot wait to see you at ACP. I'm gonna hunt you down and find you. And so just to say hi, because this is just so excellent. So we are so appreciative of your time. This is eye-opening. We would be thrilled to have you back if you'd be open to coming back again, because like we talked about, we're gonna have a series of this because we're gonna get everyone on the same page and comfortable.
Beautiful. Okay. Thank you so much.
Thanks, Dr. Klein. Appreciate it. Thank you, everyone.
Bye, everybody.
Bye.
Thank you.